We'll go ahead and get started. And hello to everyone, and thank you so much for joining us. My name is Megan Bourassa, and I am the program lead for the Micronutrient Data Innovation Alliance, or DINA for short, which is a program of the Micronutrient Forum. DINA is an alliance of diverse stakeholders working together to improve the availability, accessibility, and use of micronutrient data, especially to support national decision makers as they implement micronutrient policies and programs. On October 17th, the Micronutrient Forum and GAIN co-hosted a webinar that discussed the results and implications of the prevalence of micronutrient deficiencies in women and young children. That was published in the Lancet Global Health. We will provide a link to that article in the chat, but there was so much interest in that first webinar and so many topics that we couldn't cover. So we've decided to host a special series of our coffee and chai chat webinars over the next few months to discuss various topics that in these new estimates of micronutrient deficiencies. Today's webinar is the first in that series, and we will do a deeper dive into the methodology they use to arrive at the estimates and the data gaps that they found. We have the pleasure today of speaking with Dr. Ty Beal and Dr. Gretchen Stevens, co-authors on the Lancet Global Health paper. Most importantly, this coffee and chai chat format is an opportunity to have an interactive discussion with the participants on this call. So thank you all for joining us, and we hope that you will type your questions into the chat. And during the Q&A session, we will call on you to ask your question. You can also raise your hand if you prefer, and we'll call on you that way to ask your question as well. You will be able to unmute yourself during that portion of the webinar. So now let me introduce our two speakers. Dr. Ty Beal is a research advisor for knowledge leadership at the Global Alliance for Improved Nutrition, or GAIN, where he generates evidence to guide programs and mobilize knowledge related to global nutrition and food systems to understand what people eat and how it impacts their health and the planet. Dr. Gretchen Stevens is a descriptive epidemiologist with over 15 years of experience analyzing primary health data to monitor population health, including its determinants, with a particular focus on nutrition, non-communicable diseases, and mortality by cause. We will hear first from Dr. Beal with a brief presentation on the methodology and some of the results, and then we'll be joined by Dr. Stevens for a discussion and time for questions at the end from all of the participants. I will now pass the mic over to Ty for his presentation.
Thank you, Megan, and thank you all for joining. I'm really glad that you're here, and I'm glad that Gretchen's here so that we can hopefully answer any of the questions you may have about the analysis or data gaps. So because perhaps some of you may have not seen the kind of high-level findings, I think I'll spend just a couple minutes talking about those. If you go to the next slide. The big finding here, next slide, is that 1 in 2 children, this is preschool-age children under the age of 5, 2 in 3 women of reproductive age have at least one micronutrient deficiency. This is the kind of high-level finding from our study. These are the 2 population groups we were able to analyze with the data that we had. And this finding is pretty staggering because this is worldwide. And actually there are not any countries that we looked at where prevalence was low. So even in high-income countries, if you go to the next slide, we can see here on the right, we have high-income countries at almost 50%. So almost half of the population in high-income countries also has a deficiency, one deficiency or more for children and for women. So these numbers are really, I think, important to highlight because micronutrient deficiencies are a worldwide problem. And today we're going to get into some of the details of the methods. So next slide, please. Before that, the final kind of high-level key takeaways that we had from this analysis, besides what I mentioned previously, over half of children and 2/3 of women of reproductive age are affected by nutrient deficiency. In certain countries, specifically in Pakistan and India and Cambodia, children have very high prevalence of at least one deficiency. So this is as high as 9 in 10 or 8 in 10 children. And many women in certain countries like Bangladesh and Cameroon and others, 9 in 10 women are deficient. So I mentioned that this affects high-income countries as well. We had the UK and the US as in our data set, and surprisingly, 1 in 2 women in the UK had at least one deficiency, 1 in 3 in the US. And when we look at iron deficiency specifically, that was about 1 in 5 women in both countries. So we had this global estimate, and I'll talk about the sort of impetus for wanting to do this study, was that there's this number that we often cite in this community of 2 billion people worldwide having at least, having affected by micronutrient deficiencies. And we ultimately wanted to be able to look at this number quantitatively, but of course we had to select our population groups to what we had data for. But we do see, because of the given high prevalence and some of the prevalences that we see from a small subset of data sets, that it's likely a very big underestimate. So the total number of people with micronutrient deficiencies is actually much higher. So let's get into the methods. The next slide here talks about the first step here. So we had this initial aim, our donor, and very thankful to USAID Advancing Nutrition for funding this study. The ultimate goal was to really estimate how many people worldwide are affected by micronutrient deficiencies. And we wanted to do this in a quantitative way to estimate the point estimate and the uncertainty of that estimate. And so we were sort of initially grappling with how do we create this global estimate based on the data landscape that's available. And we quickly realized that micronutrient status biomarker data, which is what was used in the study in the final version, was really not available in high enough frequency. It was very scarce for many population groups. So older adults, for men, almost entirely absent, adolescents, and even school-age children, there were limited data. So we considered some options. We thought, what can we do with the food supply data? We know that there are some studies that have combined food composition data with FAO food balance sheets to try to estimate inadequacy of the food supply. We met with the Global Dietary Database at Tufts to see, can we use this proxy data on dietary intakes and the prevalence or the estimated prevalence of inadequate intakes. So we really wanted to explore how can we expand our data pool to really have enough data to do this for the global population. So we tried, we wanted to do that, but the relationship was weak. And when we met with the advisory panel, we had a pretty strong recommendation to really focus on the biomarkers. And so that's what we did, and it limited our population group, but that's what we had to do. Next slide, please. So first, what micronutrients to consider? Because there are 29 essential micronutrients, and beyond that, there are multiple biomarkers for single micronutrients. And we really had to figure out what are the criteria that we're going to use to make this estimate. So we looked at a few different things. I think pretty obviously the micronutrient status biomarker needed to be available in population representative surveys. And the key point here is alongside other biomarkers within the same individuals. So we can't take just data on one micronutrient, like let's say iodine, if we don't have data on other micronutrients as well, because what we were trying to estimate in this study is the prevalence of any deficiency. So that's a deficiency of one or more micronutrients. The other factor we looked at was that the deficiency in the micronutrient that we see in populations is really capable of causing severe morbidity and death. Now, all essential micronutrients are essential, and so inadequacy or deficiency over a long period of time can cause that, but we really wanted to look at nutrients that were micronutrients that had sort of a public health concern. The last thing we looked at was the prevalence of deficiency in the micronutrient being high. So we didn't want to include necessarily the micronutrients where there was really no evidence that there was a widespread deficiency. With all of those different criteria, we ended up selecting 6 micronutrients. And so iron, vitamin A, zinc, vitamin B12, folate, and vitamin D were on our list of what we are calling sentinel micronutrients. You can bear with us on the terms, but sentinel is really this sort of, what are the nutrients that we're using when we think about these different criteria for ideally being able to represent a significant burden of the micronutrient deficiencies worldwide. Okay, next slide. So in step 2, we really had to look at how do we get access to this data? How do we identify it? How do we find it? Now, thankfully, we had a partnership with Brenda pretty early on because we realized that the Brenda group at Emory University had a lot of data sets already because they are working on the biomarkers for inflammation. And we were able to gain access to that. And then we wanted to really fill in any of the gaps of the data that is out there, but that we haven't had access to. So we did a few different things. We searched the gray literature on the web through Google. We searched the peer-reviewed literature. And we also looked through the WHO Vitamin and Mineral Nutrition Information System. So this helped us identify several more data sets. And we reached out to the individuals who had who owned the data for any of that data that was not publicly available, which there were a few data sets that were. I think in the US and the UK, the data were publicly available. But we ended up being able to get access to, I believe, an additional 8 data sets. So this expanded our pool. Next slide. So the next step, the third step, was to adjust for the micronutrient biomarkers based on the inflammation recommended in the Brenda collaboration. So we wanted to use Brenda because we believe that Brenda has the most latest evidence and the most consensus for how to adjust. There are many different methods, and we're not trying to say that other methods are not valid. But when we were looking at what's the best approach on a global scale, we really felt that Brenda was the best approach. They've been working on this. Their whole project is sort of devoted to biomarkers of inflammation. So we ended up adjusting based on their recommendations for these biomarkers. So for serum retinol and retinol binding protein for children, for serum zinc for non-fasting children, and for serum ferritin for children and women. And if you go to the next slide, you can see in the paper, this is actually a table that shows a little bit more detail here. So you can actually see which groups we adjusted for inflammation for, of which biomarkers, and that was guided by the Brenda process. That's in the far right column, adjust for inflammation. Now, when we looked at how do we define deficiency, that was a question that we searched through the literature on what was the greatest consensus for thresholds. Now, these were not always used in the original publications of the data sets that we used. So oftentimes, the authors chose to use a different definition. But these thresholds were the most widely accepted in the field. And so we really felt, again, this was the best approach, is to use what has been most agreed upon. And these were something that we took to the advisory panel. We had some back and forth. We got approval on this final set of thresholds. Next slide, please. So in step 4, we go to another phase of something, and this is the core micronutrients. So before we had sentinel micronutrients, there were 6 of those. Now we're looking at core micronutrients, and what these are is that we really don't have enough data sets with all 6 of the sentinel micronutrients to make an estimate. So we were looking for a smaller subset of nutrients that would give us the pretty good proxy for the deficiency in the other nutrients. So these nutrients, we wanted to either see that they had oftentimes deficiencies that occurred alone, so they would add a lot of information about the overall prevalence of any deficiency, or which were more commonly measured. So for children, this was iron, zinc, and vitamin A. Vitamin A was not particularly high, but it was very commonly available, so it was an important one to include. For women, it was iron, zinc, and folate. Okay, so next slide, we get into step 5. So this, excuse me. So here, we are including the data sets that met these criteria. So basically, we include any of the data sets in step 2 that measured at least 2 of the 3 core micronutrients in the previous step 4. And this gave us a total of 24 data sets from nationally representative surveys in just 22 countries. So this is a pretty small amount of data sets, and we can talk about this later in the discussion if there's interest, that we really have quite a scarcity of data, even for these population groups with the most data on micronutrient status, so for women and children. Next slide, please. Now, Gretchen can get into the details of this if there's interest, but we we had an approach now. If you remember from the previous step, we included data sets that had 2 of the 3 core micronutrients. So what happens when you don't have the 3rd core micronutrient? So in this example, let's say folate. Well, if you don't include it, then we're going to be underestimating, right? Because we know that there's some prevalence of folate only deficiency. And so we used models, regression models, to estimate that missing micronutrient. So here, if you look at, we're trying to estimate B right here, this orange bar. We have a data set that doesn't have folate deficiency. It has iron and zinc deficiency. How do we estimate what the deficiency of folate only is, so that we can get at this, again, the key question in our analysis: what is the prevalence of any deficiency? So I'm not going to go into detail here, but Gretchen has more context, even looking at formulas, if you want to see those. Next step, please. And this is the last step here. So we had scarce data. So when you have scarce data, it's a pretty good use of Bayesian methods, and that's because they're kind of set up to make estimates with really scarce data, and also to help quantify the uncertainty. So we used a hierarchical logistic regression model. What this allowed is that we could actually inform the estimate for each region using data from, well, the region itself and by other regions. And this was important because some regions we only had 1 or 2 data sets, and in one region we only had 0 data sets. So we had to borrow from nearby regions, from other regions. The other thing that we included was one covariate. This is the socio-demographic index. This varied over time and allowed us to borrow strength from other countries of a similar development level. We did discuss many other potential options as covariates, and I will let Gretchen get into that if there's interest about why those didn't work. They didn't add additional value to the model. So this was the model approach. Again, if you want to get into the specifics, Gretchen can answer some of those questions, but I think that's it, unless, Megan, if you want to check to see if there's any other slides. I believe that's the last one. Hopefully we have enough time now where sort of introduce the methods, but we can get into the, hopefully the discussion of any questions that you may have about the analysis or data gaps. So I'll stop there.
Great, thank you so much. So now we'll get started with a bit of a discussion, and if others are starting to think of questions, feel free to put them in the chat so that we know that they're out there. And then in a minute, I'll call on people who want to raise their hands. But I'll get started with just a couple of questions to discuss. And one of the things that strikes me is the paper only makes estimates for non-pregnant women and young children, which means that a large proportion of the population wasn't included. So I'm curious if there was enough representative data on micronutrient deficiencies in the other life stages, or were you close to being able to make estimates for another population group? Or if you slightly altered the criteria, could more groups have been added and still done the same rigorous analysis?
Yeah, so that's a good question. I'm sure Gretchen has something to say. I can just briefly say if we had unlimited time and resources, we probably could have added potentially school-age children, and we could have looked through the WH database to see, maybe if we really had the time to try to get access to these data sets, maybe more. I'll let Gretchen if you have any sort of anything to add there.
Yeah, I think pregnant women might have been possible, but at the end of the day, we were looking for a high-level global number, and at any given point in time, pregnant women are a small percentage of the population, even though obviously their deficiency status is very important. We have the non-pregnant women as a proxy for them. And then, as Ty said, school-age children might have been next. Brenda had 10 data sets with data on school-age children, which was about half the starting point that we had for preschool-aged and non-pregnant women. For me, the 22 to 24 data sets that we did have for preschool-aged children and non-pregnant women is really the minimum. So I would not have felt comfortable doing an estimate starting from fewer. So as Ty said, unlimited time and resources, maybe we could have come up with some sort of an age-sex pattern and say, can we predict school-age children based on our preschool-age children? Can we predict men from our non-pregnant women? Potentially we could have, done that to try to come up with a complete number. But our uncertainty ranges are already quite large, and this would have increased it.
Yeah, I can understand that. So this is really quite a huge data gap that we don't have much visibility on the micronutrient status of, say, men or older people, adolescents. And so how do you think that the limited information on micronutrient deficiencies could be affecting vulnerable populations and micronutrient policy?
I can maybe take a stab at that. So I think I don't remember the person who said this initially, but you know, without data, you're another person. You're just another person with an opinion. It's something that our executive director Lawrence Haddad wrote in a blog, and I think that's pretty interesting because without data, you don't really have the impetus for policy. For one thing, we know that there are different deficiencies across country populations. So if you don't have data on specific micronutrient deficiencies, you can't just say, well, we probably have or we probably don't have a deficiency because this population in this country doesn't have it. So I think that it's pretty essential to have the data. You need that for advocacy. You need that to really, it's for action, the policy level. And there are a lot of things that we can do to try to improve diets overall, I think, which are important, but without knowing which specific micronutrients are really a problem in your population, we can't tailor interventions, I don't think, as effectively. So I think it's really important to try to broaden the scope of countries, as many countries as possible, to get data for their own sakes and for, of course, efforts to monitor trends and progress.
That kind of brings me to my next question, is really about how do we advocate for a greater investment in data to make sure that we're really guiding our policies and programs with the best available data. But is there anything we could be doing to create more demand for data?
So I think this is an advocacy issue. This is about sensitizing all stakeholders who may have ability to make a difference in this. So for one, it's with donors, really getting donors to invest in this data. And so I think, Micronutrient Farm, you're a key player here. I think we do this again, but really advocating for bringing, I think, awareness of this message. So I think one of the primary reasons we did this analysis, perhaps the primary reason, was just that, highlight that this is actually an issue worldwide. It's not something that can be ignored if we want to address malnutrition and the health burden and economic costs that come with that. And so what we need to see is that the study is published, but it's going to take a long time before all the stakeholders who need to know this information are sensitized to it. And I think we need to reach all sectors. We need to reach governments, policymakers for sure. We need to reach the private sector, civil society, and academics, so that everybody who has a role to play in either collecting more data or making a change based on the data, I think needs to know about that. So that's my take. I don't know how to go about that in a systematic way, other than we need to all sort of partner together to achieve that.
Yeah, I know we at the forum will certainly be using these estimates to advocate for more data, because there are some pretty huge gaps and also some pretty alarming levels of micronutrient deficiencies that were even greater than we had imagined.
Maybe I can also add, Megan, just that one of the things we did with this study is we tried to do a lot of additional materials for the very purpose of reaching more audiences. And so one of the things we produced, and you're aware of, but I don't know if everybody on this webinar is aware of that, we produced a policy brief. Well, I guess it's called an advocacy brief. And this is only 2 pages, but it highlights the findings in I think, a simpler way, a much more tangible way that can be impactful to policymakers and non-experts. We also wrote some blogs. We had a press release. We had a lot of different formats for this, of course, having the webinar and whatnot. So I think we're trying to get out the word, but anybody on this call and sort of just being aware that the more that we can spread the information around, the better.
Great. So I'd like to open it up to questions from the participants. The first question that we have comes from my colleague, Suzanne Furman. If you would like, you can unmute yourself and ask your question. You can also turn on your camera at this point too, to be able to do that. Or if you prefer, I can read the question as well. So.
Hi, sure. I thought it was really interesting the part about how you adjusted some of the data based on like most accepted thresholds. So I was wondering like if this could be applicable in some countries. Often in countries you might want like subnational estimates, or maybe you want to look at data in different ways. So I was interested to know if there could be a way that countries could use your method, or maybe if there's any support for countries. Yeah, thanks.
Yeah, I can try to address this. So the trickiest thing that we did were the Brenda regressions, and of course they're fully published, but going from a published paper to code is challenging. And the Brenda team were able to provide codes in R to run the Brenda regressions, so that I was able to ensure that whatever I was doing was exactly what I was supposed to be doing. And I'm not aware that they've made those fully available online yet, but I think that would be ideal because their codes were very easy to use once they were able to share them. So for the adjustments for inflammation, that's the Brenda team has some codes that they've prepared, and hopefully we'll be making those available. In terms of analyzing surveys with consistent cutoffs, I know that there's a project underway at WHO to develop a tool that would help countries to do that. And again, I don't think it's ready yet, but a lot of work has been invested in that. So I'm hoping that would also be available in the near term, so that countries can have an easier time analyzing their data.
Great. And Anna Herforth, you also had a question in the chat. Would you like to unmute yourself?
Sure. Hi. Yeah, I was following on with the previous discussion about the need for more data. And I think it's really impressive to have used available data that is there and be very transparent about the modeling effort. So thanks for that. And in terms of, this conversation about advocacy for new data, I'm just curious about what are the specifics of that? Like, which micronutrients and which populations and what does that cost? Because it's one thing to say we need more data, like we could always use more data on everything, but what is the most important data that you think, based on all the data you looked at for this modeling analysis, what's the most important gap? And there's always trade-offs between feasibility and comprehensiveness in asks for more data. So yeah, knowing the data very well as you did this work, what are the biggest, most important bangs for the buck in terms of what's needed next?
Yeah, I want to jump in, and maybe this is not the answer you're looking for, but including school-age children and adolescent males in particular. I mean, they're adolescent males, it's a period of rapid growth and we have almost no data. So I think beyond them, older adults can also be struggling with micronutrient deficiencies, and they're rarely included.
Yeah, I think I can add in. Oh, sorry, Gretchen. Yeah, so I think it's a really important question, Anna, because there are, of course, limited resources, and you have to make decisions. I think I want to highlight that when I was just trying to get a sense of what is the prevalence potentially of micronutrient deficiencies in other population groups, I haven't found any study where there's a low prevalence of deficiencies. I mean, you look at older adults, there's one study in Germany, population representative study. I mean, the prevalence is over 50%. It's a high income country. We looked at school-age children in India. It's close to the population for adolescents. So I would not be surprised if every population group has a high prevalence. When I think about the decision about which micronutrients, now on a global level, we could select what we think is important for monitoring. But I think the important thing to think about is what is the public health significance of these deficiencies. And I would say the big three probably nutrients to focus on would be iron, zinc, and folate, because we know that they have a big public health burden. They're important for many different reasons, and it may change by population group. So we may be interested in folate for women of reproductive age, but we may not be as interested in that for men, for example. The other nutrient, all of the nutrients, there are certain countries with high prevalence. So vitamin D was pretty rarely measured, scarcely measured, but there were some pretty high prevalences of vitamin D. So if I was to add a fourth, it would be vitamin D. I think we have sort of an ideal of what we want for coverage and to be able to estimate this. But I think the previous question too about what, using a standardized set of methods, what I hope can happen is that there's actually quite a bit of data sets out there that haven't either been analyzed and published on, or that have not used a sort of standard approach. So I think the more that we can have the community go towards reach consensus on what that is, and there's a lot of factors involved in that, then we have more data at our fingertips to use and compare.
Yeah, that's a really great question. We also have a question from Francis Knight around whether this has reached the ears of policymakers yet or not. Do you want to ask that yourself, Francis?
Hi, thanks, Megan, and thanks, Gretchen and Ty. Really, yeah, I mean, I think that Megan said the question. I'm really curious about whether you've had any reports yet of policymakers or politicians or anybody in some of the focus countries citing this paper or using it, and how they've communicated it in any way. Maybe it's too early.
I specifically haven't had that. I haven't heard that, but I've had quite a bit of feedback of sort of thank you for these estimates, and this is really great that we have this information. Oh, I'm so surprised, we have such high prevalence. So I'm not in those conversations with policymakers. I hope that it's starting to make its way, but we'll see, I think, over time.
Yeah, hopefully it will, all of the advocacy work that our organizations will be doing collectively in the next months to years will hopefully reach policymakers' ears. Sorrel, you had a really useful comment in the chat about the work that Brenda's doing. Do you want to speak to that? Or basically just citing the work that they're doing to update the code that'll be publicly released, but they also provide in the supplementary materials of their papers some less automated code that can be used in the meantime by others who would like to do some of the similar analyses. And I also see a question from Alvaro Perez. Would you like to ask your question out loud?
I think you said prefer not to.
Yeah, he doesn't want to.
Oh, prefer not to. Okay. So I'll read your question then. What do you think about micronutrients not covered by this study and related with obesity and non-communicable disease, considering the nutritional transition and the economic burden for health systems? That's a good question.
I can try to, I don't know the answer to this question, but I can say from the UK data, which is, a high income country with quite high prevalence of obesity and non-communicable diseases. 3 deficiencies we saw very high in women were iron, vitamin D, and folate. So those are each about 20%. And, this is going to vary by context. What was interesting is in the US, folate was, I think, non-existent from our data, from our analysis. And that could be from effective fortification, I would assume, in the US. We didn't, Gretchen, maybe you can answer this, but I don't think in our data set we didn't have vitamin D for the US, but potentially a different year there was vitamin D. I know that vitamin D can be quite common deficiency as well, even in high income countries. But iron is a big one.
I'm embarrassed to say I have to look it up. It'll take me a second.
Well, maybe I can just also expand. Iron, when you look at the UK and the US, iron deficiency for women was 20%. So I think whenever you're looking at this sort of, we're talking, nutrition transition, obesity, non-communicable diseases. One, I just want to validate what you're saying is that there are studies showing that there's actually increased risk in many contexts for people with obesity and non-communicable diseases for micronutrient deficiencies. So just having your calorie needs met is, of course, no guarantee you're going to have your nutrient needs met. Iron deficiency and zinc deficiency is also was not lower than 10% in any country. In the US, it was, I think it was,
14%.
14%, in the UK, it was 10%, right? So,
Yeah.
Iron and zinc, pretty common even in high-income countries, and probably vitamin D in many contexts.
So the US vitamin D for the women was 3%, so negligible, and probably from fortification.
Probably from fortification, yeah, exactly. So it's really going to be a case-by-case basis based on their population. Another reason to have the data, right?
Yeah, I think that makes a really interesting point to compare the fortification policies and then the prevalence of deficiencies as well, showing that it really can have an impact on micronutrient deficiencies in a very positive way. And just one last call for questions. I really appreciate those who have written in the chat and asked their questions. I know there's been quite a lot of interest in this, so I really appreciate having Ty and Gretchen join us. That first webinar, we had over 1,400 registrants, so that's really quite amazing. I really think that this paper is destined to have a long-lasting impact, at least until we can get more data to make a few more estimates of prevalence. But I really appreciate. Yeah.
Yeah, I was just going to say, Naveed in there commented on the 2018 Pakistan survey. And
yeah.
we really wanted to be able to include this data set, and we weren't able to. I don't know if it would have made a big difference to the overall numbers because the deficiency is so high, and I think the early results you're highlighting right now, it's going to be pretty similar. But certainly to see adolescents, and especially where you have data on adolescents boys as well. I mean, in India, that's the case. You can see similar prevalence, slightly lower than girls in India, but it's really high.
Yeah, very important. All right. Well, I would really like to thank both of our speakers for joining us today, as well as all of you who have participated and joined us.
There's a couple more questions coming in.
All right. Let's see. Let's go to Kevin, and then we'll go to Malui.
Hi, everyone. Thanks so much for all this. When you were looking within certain regions, did you find that there was any heterogeneity in estimates within surveys within the same region, or was it just consistently high across all of these surveys?
Yeah, I can comment to that one. So we did try to have epidemiologically relevant regions. That said, we did have heterogeneity within regions, and I'm looking figure 2 in our paper in case anyone has it in front of them, shows all of the survey data next to the final estimates. And one thing in particular that I want to flag is that we had 3 rounds of survey data from Mexico for the non-pregnant women. And we can see, we weren't able to do time trends. We had 22 or 24 data sets, so we couldn't say, what was going on over time. We basically just included everything that we could that was from 2005 or later, and we combined it all together in our model. But if we look at our 3 rounds of Mexico data, we can actually see that it seems like Mexico had an improving situation, and that contributed to the heterogeneity we saw in our Latin America estimates. So above and beyond within countries, which yes, that does exist within regions, also over time. And it would be really important, for policymaking to not only have data, but also to have time trends.
Great, thanks so much.
Yeah. And Malui, you have a comment in the chat, but would you like to address that?
Yeah, I mean, it's more of a comment than a question. And just to further reinforce the fact that, of course, in the developed world, in the US, in European countries, you have several food vehicles fortified and, from time immemorial, so contributing significantly to addressing the vitamin and mineral deficiency levels in those countries. But you take most developed countries, we are still struggling even to enforce compliance for mandatory fortification, and not to talk about, other, public health challenges that contribute to, micronutrient deficiencies like poor sanitation, constant diarrhea linked to poor water and all the challenges with, being able to diversify the diet. But even fortification is still a major challenge to enforce overall compliance for countries that even have mandatory legislations for specific food vehicles. So just to, throw more light to say that this is very important for us to generate this kind of evidence to be able to continue to push the agenda forward to, drive home the importance of, having kind of an integrated approach that would help us to really reduce the very high burdens of micronutrient deficiencies in the countries we are working in.
Yeah, absolutely. I think all of us agree it would be great to have more enforcement of fortification and improved policies and enforcement. I also see Alvaro has another comment in the chat saying that he's concerned about micronutrients like vitamin E or the risk of cardiovascular disease, or vitamin D and inflammation in obesity, type 2 diabetes, and what this might mean for health systems given the higher rates of deficiency and their links to other diseases.
I think this is an important point because when when you look at the estimated prevalence of inadequate nutrient intakes, micronutrient intakes from dietary recalls, we had a study earlier this year. We looked at this in a couple dozen countries for as many micronutrients as we could. Vitamin E comes out really high in terms of prevalence of inadequate intake. Now, I don't think we have a lot of data on the biomarkers for population-wide, but that would be a nutrient. Well, I think screening through that sort of data set of the diet, that level of data at the dietary level to say what are the inadequacies in the diet, and if we don't have those biomarkers, I would say focusing on some of those ones where the prevalence is pretty high. Another one is magnesium, so inadequate magnesium intake. So I think looking at some of those on the biomarker level is probably important to do. And if we are trying to prioritize in terms of new micronutrients to look at for biomarkers, I would start there.
Yeah, we also have micronutrients without good biomarkers too, so we're kind of completely blind there in terms of status estimates or what is actually impacting health for other micronutrients. All right, I think we will stop there. I just want to thank everyone again for joining us, our speakers, as well as all the participants. These analyses have really shown how dramatically underestimated the global burden of micronutrient deficiencies is, and that there are really large data gaps that prevent us from going further to make a global prevalence estimate for all population groups. So there's really still a lot of work to be done to fully understand this. And filling these data gaps and advocating for the collection, analysis, and use of data in micronutrient policies and programs is key to DINA's mission. So if you'd like to learn more about our group, you can find us online and visit our website. You can sign up for our newsletter, which is separate from the Micronutrient Forum, and consider becoming a member. Over the next few years, we'll have multiple opportunities for members to engage with us in strengthening the micronutrient data ecosystem. And today's webinar, just as a reminder, for the next slide, is just the first in the series of coffee and chai chat sessions that we are hosting on various topics about these estimates. The next webinar will be held on November 29th with Dr. Pranita Menon of IFPRI and Dr. Martin Molangi of M&F's Healthy Mothers, Healthy Babies Consortium. They will be discussing the programmatic implications of 2 in 3 women having at least one micronutrient deficiency and what we can do to solve these problems. We hope to see you all then, and thank you so much for joining us. Have a nice rest of your day.